So this subject, of course, we could talk about it for 3 days. I'm going to make a summary. So the indications for TAVI in 2020. Can you hear me well, by the way?
If you can just...
yes, we hear you very well.
Make it on full screen, if it's possible.
There?
Perfect.
Okay. So for patients with extreme risk at surgery, the randomized trials for SAPIEN and core valves show that TAVI was in SAPIEN better than medical therapy, of course, and in core valve was as good as SAPIEN. So the FDA approved it. For high risk, the randomized trial, and this is 5-year follow-up, showed that surgery and TAVI have equal results. And then the FDA approved it. For intermediate risk, same thing. 2-year result showed that TAVR was the same or better than surgery for SAPIEN and Evolute, and the FDA approved it. And for low risk, SAPIEN showed that TAVI was better than surgery, and Evolute was the same as surgery, and the FDA approved it. The hemodynamics of TAVI versus surgical aortic valve replacement also showed that TAVR has better valve area than surgery and less gradient. So the first conclusion today is that randomized trials have effectively proven that percutaneous treatment is as effective and safe as surgery to treat severe aortic stenosis. And as you know, that's been a revolution in medicine. Now, what's happened with the access site for TAVI? 95% today is femoral access, as shown in this TVT registry. Transapical and transaortic are no longer recommended. Anytime you enter the chest, there are more complications. Transaxillary is rarely used and is shown to have more complications than femoral. Now, if none of these are available, you can do transcarotid or transcaval. Let me show you briefly what's happened in the United States. In America, the hospital and the doctor do not get paid unless you enter the case in the Society of Thoracic Surgery and Transvalvular Therapy registry. And thanks to that, we have very good database. So there are 688 sites in the US, mostly in both coasts, which is most people live. And what have we found? This is the volumes from 2012 to 2018. Of course, TAVR is gone up tremendously. And a simple aortic valve replacement, isolated in red, is similar, 29,000, 25,000. So it's come down a little bit. What's happened, according to the European publication, in the rest of the world? So Northern Africa, which is here, in this publication, it's less than 1 per million. Germany is the highest in the world. But wait, can you see my arrow?
Yes.
Oh, okay, great. Germany has the highest with more than 150 per million. And the rest of the world, you see, is distributed in different ways. There are big parts of the world where TAVI is still not performed. What's happened to mortality? In-hospital mortality, at the beginning was 6%, now it's about 1%. So 1% mortality in the hospital is less than surgery. Now, according to risk category, For high-risk patients, intermediate and low risk. The in-hospital mortality, 2% and about 1% in blue. So that's very reasonable and very acceptable for what is usually older patients. Now, stroke rate has not changed much from 2012 to 2019. It's about 2–3%. In the hospital, 1.5% to 2%, but at 30-day, 2 or 3%. So this is something to change, and we're hoping for good cerebral protection. We still do not have a perfect one. New pacemaker. In-hospital pacemaker and 30-day, as you see, have oscillated about 10–12%. It's less of balloon expandable, it's more with self-expanding. And I'm going to talk about what we've done recently to decrease this rate of pacemakers. It's not good for the patient. The LV function does not recover as well. It's very expensive. Sometimes there are problems. The leads get infected. There's no good capture. The patient has to come for pacemaker checks. So we want to do TAVI ideally without pacemaker. Length of stay in the hospital used to be about a week. Now is 1 to 2 days. Bleeding. Bleeding is a problem. And the reason is we use a huge catheter in the femoral artery. So it's decreased from 6 or 7% to 2 or 3%, but still a problem. Now this is important. How many patients with TAVI get PCI? In the trials, about 12%. In the registries, about 25%. So you can remember, between 10% and a quarter of patients will need PCI. Frequently, they are complex lesions because they are older people. BC-type lesions, calcified lesions. The success rate is high. This low rate of lesion failure, thrombosis 0.4, restenosis 2.3. But also we've learned that incomplete revascularization pre-TAVI has increased risk. Incomplete and complete. Why is this important to remember? Because we need to consider coronary access as we choose the device for the TAVI. So that's a brief summary of what's happened with TAVR in the world now. Let me talk about new indications for TAVR. Asymptomatic severe stenosis. These are 2 trials that have shown that in asymptomatic patients, if you do early surgery, the outcome is much better than if we treat them medically, waiting for symptoms. That was by Dr. Kang, published in the New England Journal. And another one coming from Korea showed that if you do a aortic valve replacement in an asymptomatic patient with severe stenosis, the outcome at 10 years is much better, less than half the mortality than if you watch them conservatively. So how do we approach asymptomatic aortic stenosis now? We need to remember that many patients think that they are asymptomatic because they don't run, they don't ride a bike, they don't go fast upstairs. So they say, no, I feel fine. So today the guideline is, if the patient has severe stenosis and says no symptoms, you, the cardiologist, must do a stress test, which used to be contraindicated when I went to medical school. Now it's indicated to confirm asymptomatic status. And if the stress test shows arrhythmia, shortness of breath, then surgical or percutaneous replacement is indicated. There are 5 trials now evaluating the treatment of asymptomatic severe AS with TAVI. So we should know in the next couple of years what these randomized trials are showing. Another question has come up. Moderate aortic stenosis. Should we consider TAVI? And what's moderate aortic stenosis? Gradient less than 40, peak velocity less than 4, valve area more than 1. The traditional teaching is you don't touch these patients until they become severe. But let's look at the data. These are 240,000 echoes in Australia. 19,000 of them had aortic stenosis. So this is a survival at 16 years. Patients with no aortic stenosis, mild AS, moderate, and severe. Look how moderate has a same survival as severe aortic stenosis. Even mild aortic stenosis has a compromised survival. That's a big surprise. And Dr. Amanullah showed at TCT this week something very important for patients with moderate aortic stenosis. The different types. Stage 0, he calls it, with no cardiac damage. And stage 1, 2, 3, 4 have LV dilatation or hypertrophy, left atrial dilatation, mitral regurgitation, pulmonary hypertension, tricuspid regurgitation, or RV dilatation. So the approach should depend on how involved the moderate stenosis has affected the rest of the heart. And he showed this beautiful diagram, survival of 5 years. Patient with stage 0, 1, 2, 3, 4. So moderate aortic stenosis with involvement of the left ventricle, left atrium, right side, has very high mortality. 2 trials are evaluating TAVI, randomized trials. The UNLOAD trial, which I understand is fully enrolled by now, waiting for results, and the EXPAND trial for Medtronic. So we're going to have randomized data, but based on what I show you here, I suspect that we may have to consider TAVI also in moderate aortic stenosis, especially if they have high stage. Now, valve-in-valve for degenerative bioprosthetic surgical valves. And this is a diagram from the European Heart Journal. 7,000 patients. They propensity matched 2,100 for redo surgery versus TAVI. And what did they show? That TAVI had less mortality, half the mortality of surgery, had less morbidity, half the morbidity of surgery, and less bleeding, almost half the bleeding that surgery. So valve-in-valve with TAVI is much better than redo surgery, according to this big study. And what's the long-term outcome of valve-in-valve? These are 1,000 patients followed for 8 years. If they had pre-existing patient prosthesis mismatch, that means the valve was too small originally, the surgical valve for that patient. If you do valve-in-valve, the prognosis would be worse than if there was no pre-existing PPM. Now, in this study of 1,000 patients, SAPIEN valve had more reintervention than Medtronic. But you see, it's very little at 8 years, 6% and 2%. So reintervention is not a problem and the results are good. What are the pending issues for TAVI? The need for pacemaker, I mentioned, is 10 to 30%. Nowadays, we've learned that with the cusp overlap view, where you overlap the right and the left cusp, and you implant the valve much higher, the pacemaker rate published has been 2, 3, 4, 5%. Much less. So we are all changing to implant the valve in the two cusp view with better results. Stroke, which is 1 or 2%, we need a protection device that will totally protect the brain. We don't have that yet. We need to eliminate vascular complications. We don't know what to do for anticoagulation. There's valve thrombosis or valve leaflet thickening, which appears not to be serious, but we don't know much yet about it. We don't know whether a patient should be on 1 antiplatelet, 2 antiplatelets. In most big centers, these patients only get aspirin, no longer Plavix. And coronary access, as I explained earlier, is important after TAVI for many patients. So we need to plan on it. And this is a separate lecture by itself. I won't have a chance to talk about it. How do I see the future? There are new valves coming up all the time. And in this lecture, I'm not talking of the valves available. Each one of you in your own site will have access to certain valves. My advice is use the one that they give you and use it all the time and develop experience with it. But the newer valve has better performance, lower price. The group in South Africa, in Cape Town, has developed the African valve, which they told me when I saw it for TAVI was going to cost $1,000. And I know they've implanted a few already, but I don't know what the price is going to be, but you need to be in touch with them. It's a Barnard Institute of Research in Cape Town. This new technology for synthetic leaflets, which are not going to develop thickening, which may last longer, which may not need anticoagulation. I talked about total cerebral protection. There's all kinds of computer modeling and 3D printing. So you can really choose the valve size and the device choice scientifically, not just by guessing. Remote monitoring is also an important field. Implantable, but better cutaneous, or even with a watch, to use before and after the TAVI. Before, to determine which patient is having syncope from AV block as opposed to aortic stenosis, and so getting a pacemaker beforehand. And after TAVI, because it's a small percent of patients that will go to have AV block after they leave the hospital, and a few of them will die from that. And length of stay, as you know, is going to 1 day for many patients as the procedure gets simpler. So in conclusion, TAVI is now the gold standard to treat severe aortic stenosis. It's the optimal choice for degenerative bioprosthetic valves, valve-in-valve. Expanded indications are being evaluated, asymptomatic and moderate. Experienced operators are required. It's another place where remote proctoring may be of great value. Current results show high success rate and low mortality morbidity. Improved devices continue to be developed, and long-term follow-up, more than 10 years, is not yet available. Thank you very much.